Hello, everyone, and welcome to another episode of the Masterclass series from the Center for Pediatric Psychology at Oklahoma State University. In this series, we will be meeting with different health professionals and stakeholders to discuss topics and provide resources, with the ultimate goal to help pediatric psychology professionals, trainees, and caregivers navigating healthcare for their child. And on to today's episode.
So tell us a little bit about your background in training.
Yeah, so I am a clinical psychologist by training, and I went to grad school at Oklahoma State University and got my PhD in clinical psychology there back in 2016, which is kind of crazy to think about that it's been that long. I feel like I was just there. But I got my PhD there in clinical psych with a child and family sort of focus. And then after that, went on to do my internship, a residency at Baylor College of Medicine in Houston for a year. And also was on the child and family track there. And then after that year, I took sort of a non-traditional route and moved again to Charleston, South Carolina, and did more of a clinical rotation at the VA on the couples and family clinic there, where I was able to see kids around trauma kind of and family trauma in the VA, which is not very typical, which is really cool, and allowed me to get the hours toward licensure, got licensed, and then took a more research focused postdoc at Medical University of South Carolina, and then transitioned to faculty at MUSC in 2019. But a lot of my training has been in child and family traumatic stress.
Okay, so lots of moving around, but definitely a consistent path through each place that you've been.
Yeah, definitely a consistent path. I would say the one thing that was a little atypical for my path is that I took 2 postdocs, which was based for a lot of different reasons. There were professional influences, personal influences, and ultimately it ended up being 3 years of postdoc, but it allowed me to get the hours I needed for licensure, see a very different kind of population, but still around this kind of traumatic stress bubble, and then get some really good, robust training in research that allowed me to kind of get to where I am now. So.
Okay, yeah. And sounds like you were comfortable in pivoting when you realized that you wanted a career more in research versus clinical, and that's how you were able to be successful.
Yeah, I think it was the best move for me. And of course, at the time, everything feels like, oh, more training. Is this really what I need to do? And when you're in grad school, you're like ready for the end. But I really think that it was the best move for me. And I always knew that I wanted to do research and that I wanted that to be a big focus of my career. And I was still doing research when I was in the VA, but it was just a little bit more clinically focused than my second switch, I guess, at that point. So
Okay.
it was the best move for me. And I think it just shows that there are multiple ways to get to your destination, which was encouraging, I think.
Yeah, I think that can be really helpful to remember, that it's not always super linear. So what originally got you interested in clinical psychology?
That's a good question. I was an undergrad at the University of Kentucky, where I'm from, and started out pre-med. I just wasn't really passionate about it. Interestingly, watched a Friends episode that made me feel like this isn't for me. That's a story for another day. But then I took some psych classes and really liked it, and wanted to pursue that a little bit more. And my advisor said, if you want to pursue this, you need to be involved in research. And I was like, what's that? I don't know what does that mean? So then I just, joined a couple of different labs in undergrad, and I really enjoyed the research component, interacting with people. So doing clinical research, and then did a senior honors thesis. And then I actually did a master's, got my master's degree in clinical psych after, because I just wasn't sure which way I wanted to go with it. And did more research in that school there, and then applied for PhD program. So I think it was really just, I really enjoy working with people. I really want to know why, like answers to the why, and understand a little bit more about, behavior and emotional health and how kind of all these things come together, and was able to work on some projects that didn't directly involve trauma or traumatic stress, but I saw that a lot of the populations that I was working with, a lot of times they were coming from a trauma background. And so I think that's why I was like, this is really interesting for me to pursue this specialty, this subspecialty within clinical psychology as well.
Yeah, so seeing this theme of trauma, and bridging like research that can be applied clinically with clinical interests.
Yeah, definitely. And how can we start early on? I think that's why child traumatic stress specifically, because a lot of the populations I was working with were adult populations, whether it was substance use or personality disorder type of stuff. Whatever I was doing, it all seemed like there may be this theme that's sort of tying it all together. So how can we start early on and sort of prevent things from getting to this point? And so I don't know. I feel like things just sort of fell into place at that time. But it was not how I intended to start out. And then here I am.
Yeah, a long road later, we made it.
Yes. Yes.
So in line with that, why do you think it is important for psychologists to be involved, kind of in that early intervention aspect of trauma?
Yeah. I think, psychologists play, and I don't know that it's unique to psychologists. I think mental health workers in general, but I think that the earlier that we can intervene, I mean, the research shows us over and over and over that early intervention is key for so many different outcomes that we're looking at. And so if we can sort of insert clinical psychologists in these different sorts of settings that are sometimes non-traditional, and I think that we would see a lot of ways that we can be supportive, that we can maybe assess these types of difficulties or conditions early on, especially when it comes to trauma. I'm a big fan of being able to integrate trauma screens in these sort of different settings so that we can assess a little bit early on and know what to look out for so that we can provide people with the help that they need earlier, rather than waiting years and years and years until people have been dealing with these symptoms for, sometimes decades. And how can we sort of intervene early on and then get them connected either to mental health treatment or other types of support that may be helpful for them? I think we can play a really key role in that.
Absolutely. And I'm curious how you picture that or see that being played out within healthcare settings, with the caregivers and the child.
I think it's key, actually, to do this within healthcare settings. And I didn't start out this way. Again, this may be the theme of the day, that this wasn't how things started out. In healthcare settings, or really see myself in that kind of position. But that's where I am. And I think that it's really helpful for us, to have a role in healthcare settings specifically. I mean, you could involve yourself in, as a psychologist or mental health professional, in more traditional kinds of community agency settings, mental health settings, which is great and fantastic. And there's definitely a place for that. And you're going to maybe only get a subset of those people who need the help or who know that they need the help. And what we know is that the majority of people who need mental health treatment don't seek it. And a lot of those people don't know how, or don't know that they have the need, and that they don't know how to do that. So if we think about healthcare settings specifically, these are oftentimes places where people are already going for other types of conditions, whether they be chronic conditions or more acute kinds of conditions. And so then if we can have resources in place for those folks who are either struggling with a medical procedure, or who are, this is just one of the many different things that's going on for them that's difficult, and somebody notices something or knows what to screen for, knows what to look for, then they can make that referral to a psychologist. I think that can be key to getting them, again, that help earlier than they would maybe do it otherwise. So I think we can play a really key role.
Absolutely. I completely agree with you there. And since you work like in this healthcare setting, what are some of the unique psychosocial needs of the population you serve of pediatric injury?
Yeah. So, and I'm realizing I didn't talk specifically about kids or caregivers with that last part, so I can try to weave that in here. I know that that's key as well. So we have a program at the Medical University of South Carolina called the Trauma Resilience and Recovery Program, TRRP. And it is essentially a program where we see these patients coming in, and we treat patients ages 0 to 100, but I focus more on the child and family population, and I'm the associate director of our program for kids. So they come in after they've experienced a traumatic injury, and we're not talking about the ones that just, they sprain their ankle after falling off their skateboard. We're talking about the ones that bring them in for at least 24 hours. They're hospitalized for oftentimes it's motor vehicle collisions. We see gunshot wounds, stabbings, and other types of interpersonal assault, falls, animal attacks, things like that. So they come in, and it's in the time, the most acute time after their injury. And so it's a really scary time oftentimes for anybody, but then especially imagine a young kid or a kid of any age who's just experienced this traumatic injury. So we then will screen them for acute stress symptoms, give them some education for some things to look out for in terms of their mental health recovery. We say you've got lots of great doctors and nurses and a team of people coming in here to focus on your physical recovery. And we just want to make sure that you're thinking about how you're feeling and what it might be like for you when you leave the hospital and you have to get back in a car, which is the thing that got you here, for example, or you have to go back home and see your dog. And, whenever the neighbor's dog attacked you and things like that. So we just want to kind of get them thinking about traumatic stress reactions and normalize that, and then also let them make sure that they're monitoring. So it can be a really scary time for these kids, and it can be a really scary time for their caregivers as well. And so that's kind of been the focus of our work, and what we're seeing is that if we just intervened with the kid, we might be missing a bigger opportunity to do better work, do more thorough work by involving the caregiver in these types of discussions as well, especially for our younger kid population. And so caregivers, what we know from the literature, and I know I'm preaching to the choir here, but is that over and over we see caregiver distress being significantly linked to child emotional recovery after traumatic events or after kind of significant events. And so we make sure to focus on caregiver mental health and child mental health after pediatric injury. Sometimes we see the kid is totally fine after. We see up to about 40%, I think, of our child population is experiencing more acute stress symptoms or PTSD or depression in the weeks and months following their injury. But sometimes, the majority of those kids are fine, just like we see in the normal population, but it's oftentimes those caregivers who are not fine. And in our own population, we've looked to see that 2/3 of our caregivers actually meet clinical significance for emotional distress, for really high distress levels after their kid's injury, even if they weren't involved, even if they didn't see it, even if they were at work when the whole thing happened. And oftentimes kids are like, I'm good. I'm ready to get back on my bike again after this. And mom's like, yeah, no, bikes are unsafe. You're not going to get back on a bicycle ever. So after this injury. And so we have discussions around what's a normal kind of response after this, and what's more distress driven. And then how can we just weave safety in there? So is it normal to make sure that they never get back on the bicycle ever again? Or can we talk about ways well, you're going to wear a helmet and you're going to be careful, and we're going to integrate some kind of safety precautions, but it's okay to get back on the bicycle if you were doing it safely before that. So I think those are the main outcomes that we're really looking for. Would be acute stress in the hospital. We follow up with them over time as well. So then we're looking at more post-traumatic stress symptoms. which is a little bit of a smaller number, of course, because we should see that stress, the acute stress decrease over time, but it certainly exists. Depression is another one that we're looking for. I would say with these kids, we often see anecdotally, and I keep saying I'm going to look at the data on this within our program and haven't yet, but anecdotally, I would say I hear a lot about depression and mood related issues with our kids specifically because they were so active before, they were in sports and hanging out with their friends, and then now this injury has caused them to have to recover and be in their room, maybe alone. Now they're not really seeing a whole lot of people, so then that can affect mood and interest in things that they used to enjoy. And so those are oftentimes the things that we are looking out for and encourage caregivers and kids themselves to look out for after pediatric injury.
Absolutely. And so if you do notice mental health concerns in caregivers, are you referring out or do you follow them long term? What does that look like?
Yeah, with our program, we are fortunate that we have the resources to be able to provide those services ourselves. We also recognize that a lot of trauma centers across the US, and we've done some research on this as well and partnered with other trauma centers to determine feasibility of implementing our program in those centers. And we've been successful across the Carolinas, which is nice, but we realize that a lot of them don't have the capacity that we have. So we tailor it depending on what they have and what their infrastructure looks like. But for us, yes, we do provide those services. So it's a stepped care model where we start in the hospital with them and, like I said, do a brief acute stress screen with caregivers and or kids, depending on age. And then we have a second step of our program, which is a text messaging service where caregivers will get 2 texts a day for 30 days after their kid was hospitalized for injury. The idea is we don't want to give everybody everything, all the resources, because we know that most won't need it. So this is a least resource intensive way to be able to still provide them with those services. So they get 2 texts a day, one to monitor their own mental health symptoms, and one to monitor their child's emotional or behavioral health symptoms. And so then they respond. It's basically like, how much have you been feeling anxious today? Something like that. And then they can respond on a scale of 1 to 5. And then depending on how they respond, they'll get a corresponding tip for something that they can do, just one small thing that they can do that day to help with sleep hygiene or to help with, more weaving in behavioral activation sorts of principles, things like that. Same for their kid. They'll respond about how their child has been doing, and then they'll get a corresponding tip for something that they can do to help accelerate their child's emotional health recovery, with the idea that it's a symptom self-monitoring service where they can monitor their own and their child's symptoms. So that happens for 30 days. We want to give it time for that natural recovery period to take place. Then about a month later, those caregivers will get automated screens where they can do a little bit more of a thorough assessment of their own distress level 30 days later and their child's, depending on their child's age, of course, again. So again, for a 1-year-old or 0-year-old, we're not going to be asking them those questions, but depending on age, they'll fill out more questionnaires at that point. And then those folks who are significant or who request services, we are able to provide evidence-based, usually trauma-focused treatments, whether it's trauma-focused cognitive behavioral therapy to the kids, prolonged exposure to caregivers who need it. Sometimes caregivers were also involved in their injury and require services, behavioral activation, cognitive processing therapy, other types of evidence-based treatment as needed, but not to everyone. Again, it's just whoever needs it at that point.
Yeah, I really like that. I think it's really cool that they get like really in time tips. And it's not like super overwhelming because it's just 2 a day. But then at the end, once you allow for that natural recovery process, you do screen everyone. I think that's awesome.
Thank you. Yeah, we just piloted. I just completed a pilot, and we have a manuscript under review currently at the Journal of Pediatric Surgery, but really just kind of looking at caregiver feedback. So we piloted that out. I thought caregivers would be overwhelmed and maybe frustrated by 2 texts a day. And right in that aftermath, after their kid got hurt, they've got hospital bills, they've got routines they're trying to reestablish, childcare issues, work issues. And I thought maybe they'd want all the tips at once or something, or I'm sorry, all the questions at once and tips. And they said, nope, we don't want that. Keep doing it this way. And I said, really? Even you want the text too? Is that not overwhelming? Yes, we want text. We want you to send it via text. I'm already in my text app multiple times a day anyway. So please keep sending them to us. And we got really great responses. And I said, okay, great. Well, we'll keep doing it. So
Yeah, that's awesome. Because I know it can feel like a lot sometimes when you're emailing, and so I think that's great. And
yeah.
it's nice that you were able to get that feedback and incorporate it.
Yeah, definitely. It's always an iterative process. We're always trying to get feedback and incorporate it at every step along the way, which is great, and how we feel like you should do it, but overwhelming at times too.
Absolutely. And so being where you are now, and in this line of research, and within the larger program, how did you become involved in that?
Yeah. Again, not how I pictured things happening. So when I was in graduate school, I really focused a lot more on child abuse and neglect prevention, and I'm still very passionate about that and love that area, and hope that I can get back to that at some point, or I can incorporate that somehow. But that's really how I started, and then moved to where I am now. I think I just saw opportunities. Again, I saw whenever I moved to Charleston for my first postdoc, I'd never worked in a VA before. I never saw myself doing anything like that, because I was like, no, I'm like child child maltreatment specifically. It turns out you see a lot of that too there. So, but I really saw an opportunity for, again, a psychologist in this kind of a role with families, with kids in a VA where people are already going to be coming for their services. So why not treat the whole family? Why not try to assess, trauma symptoms in the whole family? So it sort of goes back to that theme of where can we put psychologists in these places? Not that that's anything novel for a psychologist to be in a VA, but for kids specifically and for families, I saw it as a great novel opportunity. And then I sort of made some other connections along the way whenever I was there, and learned about this other postdoc experience or opportunity that where I could join and still do child trauma focused research. Child and caregiver specifically focused research with a pretty new population, traumatic injury. And so I took that opportunity and just learned a lot about it, and started and saw that there was another niche again that needed to be filled for our younger kid population specifically. So those kids under the age of 12 who've experienced pediatric injury and their caregivers. And so I thought, well, this still feels within that realm of child traumatic stress for me. I think that there are opportunities to be had here where we can maybe build some interventions for these families that don't exist in trauma centers. And wouldn't it be cool if we could build an intervention that could then be applied to other types of trauma populations like child abuse and neglect? So again, I hope to get back to that at some point and bring it in. And so then I just really saw this opportunity, not specifically for this is where I have to go and the only niche that I can fill here, but how can we then broaden this to other populations, and not just here at MUSC with pediatric injury, but then maybe I could build something that other trauma centers could find helpful and useful as well. And so that's sort of where I see my program of research going, is being able to develop something that we find feasible here, that then we can offer as a cost-effective, sort of scalable and sustainable solution for other trauma centers that maybe aren't addressing child mental health or caregiver mental health after pediatric injury, but want to be. And we've done some research on that too, and learned that that is the case, that most aren't and all want to. So I see it as a great opportunity to sort of build that program of research more broadly, and broaden it to other types of settings, potentially primary care settings if we want to do that, or other places, emergency departments as well, and also other populations. So, and just grow it.
Yeah, I love that. And something that kept coming to mind was the word innovation. And it just seems like you were very innovative in every opportunity that you took, and kind of like just taking advantage of it and filling in the gaps with your knowledge base. And now being able to build it within this one specific population, but you'll be able to generalize it to what you originally started with, which I think is really cool.
Yeah, thank you. I appreciate that. And that's the hope. I mean, I think some of it was just, this makes sense for me right now. And I think for anybody who's trying to figure out what to do and where to go, and this is what I'm taught in grad school, I have to do this one path and it's academia or bust, or, I think it was important for me to listen to that and to know what was important for me professionally, but then also personally, and what was right for my family. And so it felt like things just kind of made sense to follow those different types of directions, and be able to find something that applies again to those other populations. I think it's good to be flexible as much as we can. I think it's a good skill to have as a psychologist in general, but also maybe as a human being. I don't know. To be flexible, but to not only serve multiple communities or to serve vulnerable populations that may not be getting care otherwise. But if you are really interested in academia or research and building a program of research, that's what NIH wants to fund as well. Is how we don't want to put this money towards something that's only going to apply to this one specific population, but how can you really broaden it to these other groups or other settings or other types of caregivers, for example. And I think it could be a win-win at that point.
Absolutely. And so thinking about your program, have your goals for it, I know like testing this intervention and applying it to other populations, has that remained the same? Have your goals shifted over time for the program? And what does that kind of look like for you?
Yeah. I would say originally it shifted, as I mentioned, where I never saw myself being in this type of a role working with this population. So that has shifted, I think, over time. And I would say as I do more research, more quality improvement initiatives, learning more from families, learning more from trauma centers too, about what their needs are, learning more about the field of implementation science and what's going to make sense for, what I think is going to be great for these families may not line up with what trauma centers think are going to be great for these families, or what families think are going to be great for them. So I would say in some sense, yes. I mean, I think you have to. I think it has to sort of change a little bit based on what needs are out there. And so, yeah, I mean, I would say that my program of research is probably the thing that's going to remain the same with it, is that I see myself as an interventionist and someone who develops and tests clinical interventions for traumatic stress populations. So that's something that I am really passionate about and really want to continue to do. How that looks and with whom, I think is something that could be more flexible around, and based on what the needs are, again, for key stakeholders, being the families themselves, being trauma center leadership or other types of healthcare leadership, what policies are out there that may affect some of these initiatives. I think those types of things could change over time, but yeah.
Absolutely. And I think it all just comes back to being flexible as psychologists.
Yes, I think so.
So I'm curious, with your research program, what are some of the outcomes that you've found?
One of the things that we have really looked at, I think one thing that's allowed me to be successful where I am now is kind of, I saw this pipeline along the way for how to build and test this intervention to get where I am now. But we started with a lot of, again, qualitative interviews, QI initiatives to figure out what the needs were. of this population, and how interested families would even be in an intervention like this, and how interested they would be in technology specifically. So early on, what we found is I was able to secure a little bit of pilot funding to help answer some of these questions. But early on, what we found is, yes, caregivers are distressed. Yes, kids are distressed. And yes, they influence each other after pediatric injury. And yes, they would be interested in something like an app or a website or a text messaging program, as I mentioned before, to help accelerate their emotional health recovery. I think caregivers sometimes feel like they don't put themselves first after their kid's injury. And I think it makes sense. As a mom myself, I could see myself saying the same thing, but where we get the buy-in is this is gonna, if you can take some time for yourself, if you can focus on your own mental health care, you're going to be able to be that parent that you want to be for your kids. So I think they're very interested in some kind of intervention that will help accelerate their own emotional health and their child's. So we have found that that's true early on. When we look at our data down the road and we continue to follow these families, we see that about 40% of these kids meet criteria for post-traumatic stress disorder or depression after pediatric injury. I would say fewer caregivers maybe meet those criteria. I think it's probably flipped. Like in hospital, we have caregivers who are really distressed and kids who are distressed, but not as much. And then when we look about 30 days later or longer, we usually see that kids are experiencing more of those symptoms than caregivers. But certainly if the caregivers are, we'll treat them as well and give them resources. So caregivers are enthusiastic, I think, about the idea for some kind of an intervention and how they can help themselves and their kids. I also just completed a national survey, a mixed methods survey, a quantitative and qualitative project with trauma centers, pediatric trauma centers across the country, to learn about what kinds of mental health resources that they have or lack, or wish that they had in there. Yeah, I think that it's really important to do that kind of work early on whenever you are wanting to develop some kind of a resource or intervention for these families. Because again, I could think that this is the best resource ever and that everybody's going to use it and that this is, I'm a genius. I've created the greatest thing. But it's only going to mean so much if there's not going to be any uptake or any trauma centers who are interested in adopting the intervention. So I think it's important to understand what their needs are now and what they're already doing so that you can then build something that kind of can be adapted and well integrated within their workflow and infrastructure versus giving them one more thing that they have to do on top of everything else when they're so busy.
Right.
So we just published that paper as well. Also in Journal of Pediatric Surgery, and then another one that is under review as well. And what we've learned is that overall, yes, trauma centers are very interested in this type of thing. They value mental health, and they want to be able to provide some services for these families. And they oftentimes lack the staff, the funding, the time to be able to do something like that. So then we talked a little bit about technology, and no one is using technology in in these settings of the people that we surveyed, which was 83 trauma centers across 36 states. No one is using technology really for mental health care resources. But I think it offers a really good low cost, low burden solution so that maybe you can automate screens in the hospital so that we don't have to have all these people that are doing tons of work. You can automate follow-up screens potentially for them so that you don't have to have people calling, 30 days later whenever they already have their huge caseload in the hospital or in these trauma centers. So I think we see a lot of great opportunity to be able to integrate this resource and implement it within existing infrastructure. And trauma centers are enthusiastic about it if they can make it work within their flow. So
yeah, I think I'm like so interested and excited that you did so much work on the back end, because I think as trainees especially, that's kind of missed sometimes, and we don't hear about that. We get so excited about our findings and intervention that it's we skip like, well, are you actually going to use this? Do you want this? Do you have resources for it? So I appreciated hearing that whole backstory. It was really helpful. So actually, that was my next question about your long-term goals and where you see this going.
Yeah. So again, I wanted to develop something that I could build my program of research, my career off of. And I hope that anybody interested in a career development award or anything like that can maybe think about that too, is where can I see this going and how can I make this bigger? So plans for this project are to we're still in the thick of my K-23 funded by the National Institute of Child Health and Human Development and SEHD. We're still testing out, is this feasible? Can I even do what I said that I was going to do? And then next year, the plan is to submit an R01 in June to be able to then test effectiveness. It'll be a hybrid one effectiveness implementation trial, multi-site trial, where I can test effectiveness and then also implementation feasibility within these different trauma centers to determine if it works. So once we determine it works, hopefully, as everybody wants to know about their research, I'd really like to then take this into the implementation science world again, and maybe with the next step being a hybrid 3, where I'm really looking at implementation strategies and outcomes specifically, because it's not enough to know, okay, this works great, but if it's going to cost a ton of money, or if it's going to take all these weeks and weeks and for people to do it and all this staff, then it's not feasible. So I hope to be able to take this to the next stage, which is determining, okay, how can we, again, fit this into existing infrastructure in these trauma centers, and then maybe broaden it from there and be able to look at emergency departments. Wouldn't it be cool if we could screen everybody coming in for an injury in the emergency department? Because who are we to say what's traumatic and what's not? And be able to kind of do more assessment of social determinants of health within all of this, and understand what kinds of needs that this population has for our violent injury population specifically, where we see some differences there. How can we address things, big drivers of a lot of these outcomes within these interventions, like housing, and making sure that there's food security and safe housing, all these things that we can see and we can screen for in an emergency department setting or a primary care setting or things like that. And then based on what we learn in the screens, including acute stress and depression, all those types of things that I mentioned, then being able to triage them from there and figure out what resources are needed and how to build and sustain community partnerships with the trauma centers, with the emergency department, so that they know where to refer people and where people can go. Maybe they don't have psychologists, or maybe they don't have psychiatrists on staff, but do they have great relationships that they can build with community partners that can kind of take the reins at that point? So that's big, I guess, but hoping that can kind of go to that point.
Yeah, well, while you're talking about screening, I'm like, there's such a need for that. And so I'm really excited by this. And you obviously have a lot going on in the works and future plans. So what are you particularly proud of so far?
I mean, personally, this probably isn't really what you're getting at, but personally, I'm proud of where I started and where I came from and where I am now. Like starting in your training and thinking about where I was as a grad student with like zero self-confidence, and I have no idea what I'm doing, and someone's going to find out one day that I just am so green and don't know what's going on, to now being able to get to this point where I still feel that absolutely at multiple points in the day. But I have such a good team behind me too, and in front of me and around me, and that's been so supportive that it's been, and now I have NIH funding and hope to continue to pursue NIH funding. And not that that's like the outcome of success. It's definitely not. There's lots of different ways to measure success in this field, and I think we should do a better job of that, and acknowledging that. But being able to just sort of see my trajectory and where I came from, and and get to this point has been something that I'm proud of, I guess.
Absolutely. And I think that's so encouraging for trainees to hear, including myself, of just like, I guess, looking back over your path and kind of seeing how you put all these pieces together to now have the program that you're working on now, and just how everything has come together and you've worked so hard to do that. Even though along the way it might not feel so straightforward and so nicely put together. But yeah, I definitely think that that's important for trainees to hear.
Yeah, thank you. I think so too. It was not planned like this. And I think one thing that was not helpful for me as a trainee was people would always say, I don't know, things just fall into place. It just sort of happened. I'm like, well, that's not helpful. I need to know
Right.
how to get to that point. And I think it's just really about listening to whatever is most important for you in that season of life, and really knowing, okay, what's going on for me personally and professionally? What are some good opportunities? How can I maybe think outside the box about other opportunities, like the VA opportunity that came up for me? I never thought I would see myself in that kind of a position, just because of the population that I worked with specifically. And the VA, I was like, I've never even, like, I don't even know if I've stepped foot in a VA before. But I really saw it more, again, because of these professional and personal drivers, to be closer to home, and things like that that were important to me at that time. I saw it as an opportunity to build relationships with people who, there's a lot of research happening at the VA, but not a whole lot with kids and families. So maybe I could start to build a program in that way, or fill this niche that's not there. So I think just listening to whatever's important, at that season of life for you, um, and taking into consideration professional, personal, other important people in your life, and going forward.
Yeah. And again, taking advantage of the opportunity.
Yeah.
And so you mentioned measuring success. And so I was just kind of curious, professionally, what success are you most proud of?
I think at the time that I got my K, it was like, okay, I've made it. This is it. And that's a little sad because, not to minimize it, because it's a really great accomplishment. It really is. But it's also like the first step, or it's not really the first. Grad school, I guess, is the first, but professionally, it's like the first step, and so many others beyond that. But I think that was something that I was really proud of, was to be able to secure national, or NIH funding. And so, but I also don't think that that's the only way to do it. I also wonder sometimes if that's the only way that we measure success. Are we missing opportunities to be able to actually serve the communities that we want to serve, because it takes so long sometimes to go from NIH funding to actually getting resources into the hands of people who need it. So again, I think there's lots of different ways to be able to measure success. And I really just think one thing I'm really proud of too is, I think involving key stakeholders along the way, and being able to, it allows me to kind of stay in touch with that community, and not just say like they're put my research hat on at all times, but to be able to actually, involve parents in the process of developing and refining a million other times, these interventions. Being able to talk with, I love doing that study. I love doing the phone interviews with the, trauma center leaders, to be able to understand a little bit more about, what their needs were, and what they wanted, and what they hoped for. So I think also like stakeholder involvement has been something I'm proud of, I guess, or maybe excited about.
Absolutely. I was actually wondering if you were going to mention that, because just looking in as a trainee, and like something important to me is including families and stakeholders. And so I can see that would be something that I would be very proud of. And it's exciting to be able to do that. And I think it's an important reminder that like securing funding and securing NIH funding isn't the end all be all. It does feel really good when you get your first one as like an independent researcher. However, there are many ways to go about it.
So many different ways. And I think that we should try to think about other ways. And I hope NIH also can incorporate and start to think about, ways that we can, involve communities more, and make that more of a priority as well, so that we can get this work into the hands of families who need it. I carry a caseload, a very small caseload of traumatic injury patients to help inform my research and vice versa. So currently I have like one, it's just one, but I have one patient. I usually will take on, depending on what I'm working on, one or two patients at a time to be able, so that I'm still connected and still understand what their needs are. And I think that that's something that I'm proud of, and I hope that I don't lose sight of, because it's easy to get really busy and inundated with research stuff and priorities, that it can be hard to say, oh, okay, well, let me just take on another patient. But then once you do it, I feel like I hear the stories and I think, okay, this is why this is important. This brings it back. And I think I hope that that's something that I can continue to hold on to throughout my career.
I really like hearing that, because I think something trainees hear of a lot is this, like, you're never going to have a 50-50 split. And being someone who doesn't want that, and it is really interested in research, but also bridging that with the clinical stories, I think is so important and so cool that you are able to do that.
Yeah, thank you.
Okay, so how has the field of pediatric psychology grown over your career so far?
Oh, that's hard for me to answer because I didn't start out as
I
a
just
pediatric.
realized that.
Yeah, and that's okay. I didn't start out as a pediatric psychologist, and it's still hard for me to even picture myself as that. I guess that's what I am. But I think I'm newer to the field than maybe a whole lot of other people. Again, just because of the way that things worked out and kind of pivoting in my career. So for me, I'm just seeing more and more mental health involvement in these kind of non-traditional healthcare settings. And I'd like to continue to see more of that. So although I can't speak to where it started and where it is now, that's something that I've really noticed, is that we're trying to plug in mental health where we can, in non-traditional healthcare settings. I feel like primary care was a big one for a very long time and still is, and in traditional hospital settings for chronic illness, and it's all super important. But I'm wondering again about other types of places that people go, like for injury or for their ortho checkups, or for, other types of things that, or maybe we can keep inserting psychology.
Yeah, keep expanding and getting that interdisciplinary teaming.
Yeah, and I think the big thing for me that I've really noticed is this emphasis on caregivers. And really, maybe that's always been the case, and people see this and think, oh, wow, yeah, that's welcome to the game. But for me, I feel like there's been this big growth that I've noticed for people focusing on caregivers and their distress, specifically after, whenever their kids have chronic conditions or acute conditions or things like that. So that's been pretty cool to see.
Yeah, and seeing a need for psychologists for the caregivers in the children's hospital, which I think is a little new.
Exactly. Yeah. And being sure to incorporate them at every step along the way, and not just so that we can get parent report of child symptoms, but parent report of parent symptoms, and make sure that because they influence each other. And so how can we, even if you are too strapped to be able to offer those services to the parent, how can we at least assess for it and then make sure that there are handouts or resources or whatever else for those parents, I think is key.
Absolutely. Well, thank you for sharing that. I am curious now, what advice you have for trainees who are interested in having a career similar to yours in research, and building a program.
Yeah. Oh, so much. Learn from all my mistakes along the way. I mean, there have been successes, of course, too, but no. I think in addition to being flexible, because I really think that over and over, I interview interns who come here for our program at MUSC, and they ask what's going to make me successful, or what would make an intern successful in your program. And I always say flexibility. I think flexibility is key. But in addition to that, I think the biggest thing, that the advice I would give, is get yourself a supportive mentor team around you. at every stage of your career. Start now. And I don't just mean your primary advisor and whoever you're working with in graduate school, but who are other people that can really serve that role for you and maybe different functions. So for me, I had, my primary advisor in graduate school, and then I also had some other folks who our content areas weren't similar. So I didn't go to them for that kind of advice. But it was really helpful to kind of get professional development types of mentorship from other professors in the department. Then beyond that, it was really helpful to work with a team of people. And then now my mentorship team has been so helpful in guiding me, reining me in, and saying, okay, you're postdoc, which is great, but you can't save the world right now. Like, let's talk about what are the small steps that you can do. And they've just been so key to my success, I think. And I feel so supported right now in my career as an early career investigator I don't feel stupid asking questions that are probably stupid. I don't feel, I feel heard. I feel valued for the most part, and I think that that's great to be able to find yourself a team that really supports you, that values you, and that shows you what you're worth, because you're worth a lot, even though you may feel just like a grad student or just like a postdoc, as I've introduced myself a million times over the years. But you're making a big difference, and find people who see that in you as well.
Yeah, I really like that, building your team. Do you have any advice of like how to seek those people out or how to like foster those relationships?
Yeah, that's so hard. What I did is stepped out of my comfort zone and networked. And I hated doing it, and I still don't love it. I get anxious about it. I just went to a conference this weekend, and I was like psyching myself up. Okay, you're gonna go talk to this person. It's okay. Like, you do cool stuff. It's fine.
Yep.
And it ends up always being great. And they're so nice. I mean, it always ends up being fine. But what I did was, really just putting myself out there, and I would email people and not feel, and sometimes it was just cold emails, or, hey, I went to your talk at Grand Rounds on XYZ, and I'm really interested in that. Would you mind to set up a 30-minute meeting with me sometime to chat further about your research? And that led to other connections, and that led to more connections. And so a lot of those I've still maintained over the years. And then on my K-23 now, I have a specific team of mentors that I reach out to. And I think knowing what they can provide you and what their role is and what those limits are too has been key. So putting yourself out there, and even when you feel anxious and you don't want to do it at conferences because you just want to go hang out with your friends, really doing it, and fostering that through some emails and through, hey, we haven't chatted in a while. I have some ideas around this research idea. I wanted to update you on my progress thus far. Could you meet with me for 30 minutes? And that's led to so many other connections.
So really putting yourself out there.
Yeah, even when it doesn't feel good at first, it will pay off.
Yeah, it sounds like being really intentional too, like going for mentors that will be able to support you, or at least like be able to have that conversation.
Yeah, I mean, I have mentors that I work with that are clinical psychologists and have been through similar trajectories as I have. And then I have some pediatric trauma surgeons that I talk to and work with as mentors. And I know that their time is limited, and I know that they're not going to be able to sit down with me like for a full hour like I force my mentor to do every week. But I know that exactly being intentional, knowing what I want to get out of this meeting and how I can get my needs met, and then how I can also give back to them and maybe their patients somehow, or their program. So really having that bi-directional relationship when you can, and then and continuing that process along the way. I don't think mentorship stops whenever you get your faculty position. I think you should always have mentors. And then I think that it's important to mentor other people as well. So it's sort of it's been cool for me to grow as a mentee and then also a mentor to others. So
Absolutely, passing that on. And what you were lucky enough to receive along the way.
Yeah, hopefully. I mean, talk to my mentees and see what they think, but I don't know.
I'm sure they have wonderful things to say. So switching gears just a little bit, obviously we're in the middle of a pandemic still, so we're kind of curious just how COVID has impacted your research, and this whole program you have going.
Yeah. I mean, who isn't impacted by COVID? We, I think the most obvious things are probably just in person to virtual. And before, when I talked about our model, our step care model, it started with us going on the floor to see patients in the hospital who just experienced injury. So when COVID first hit, everything was shut down, and then we had to figure out how to pivot that to a more virtual model. How do we go in and see these patients? Are we really key personnel that needs to go into the hospitals, and what kind of risks are we willing for our team to make or to take for that population? So we actually published a paper on how we went from in-person. It was actually a more hybrid model. We were doing telehealth prior to the pandemic for our last step of the model for evidence-based care. But how we transitioned from that to fully virtual model. And that's led by Margaret Anton and colleagues. So I think that's been the most obvious thing. We were then calling into patient rooms, which was just kind of awkward, and it was a lot of phone calls. And but I mean, we were still able to get the screens. We were still able to provide some services that way. How can we use iPads that are or existing technology to be able to come through on the screen with patients? And we were a little bit less successful in that way, but I think the biggest thing has been to really lean on our partners in our trauma centers. And so I feel like probably now the nurses that we work with and social workers will hide every time that they see me, because we really leaned on them a lot. Whenever they were still in the hospital, we would call. If we couldn't get into the patient rooms, we would call the nurses station to be able to have them connect us to the patient and track them down. And when are they going to be back in the room, and how can we talk to them? So those types of things have been difficult. And we also realize, as I think probably lots of different labs have learned, we can still be successful for the most part doing our research virtually. And so just trying to use telehealth modalities when we can. We're a technology team where we're building technology. Part of my intervention is building an app for these caregivers so that they can kind of focus on their own emotional health recovery, get coping skills, relaxation skills, psychoeducation in an app in that, those weeks after their kid gets hurt. So how can we, the text messaging system. So some of it was already kind of well integrated, I think, in a way that was helpful for us, but also came with a lot of challenges. And so that's been kind of the biggest thing. And only recently, in recent months, have we been really transitioning back into the hospital full time. So
Okay. Yeah. So it sounds like, again, being flexible, and then also having that really strong team of healthcare providers helping you out, which I know is so important when we're doing research in the hospital.
Absolutely. Yeah. And we are so lucky because they really value our program, and they lean on us too. They'll say, we have patients that need some help. They're experiencing this kind of distress. Can you work with them? So we want to give back too whenever we can, but really being able to lean on those partners has been key.
Yeah, keeping that strong relationship.
Yeah.
Well, cool. Is there anything else that you would like to share today with professionals or trainees that we haven't talked about?
Oh, I don't think so. We covered a lot. I mean, I think it's, again, just important to have that team, important to measure success differently whenever you can, and really just thinking about what do I want my influence to be down the road, and where do I want to take this? How can I not only be successful for me, but how can I make an impact on the community? Because like to think as clinical psychologists. That's why we started doing this in the first place, was to make an impact. And so really thinking about community impact, not just how can I get the next grant and pay for my funding and or pay for myself and my team, which is very, very important and a real stressor. But what can I do that's going to allow me to do that? And then also make an impact on the community that I want to serve, and how can I make sure that we're reaching more people? I just think that that's a key thing for us to come back to, no matter how far removed or how far you are out of grad school.
Yeah. And I know as a trainee, that was really helpful for me to hear. And it's always a good reminder to step back and think about what we actually want to accomplish, because we do get so excited about the little things, which is good, but it's nice to have that reminder about what you actually, who you want to impact and what you want to do.
Yeah, absolutely.
So thank you so much for talking with us today.
We hope you gained as much as we did from today's episode. You can find more episodes like this on Apple and Spotify podcasts and our YouTube channel. Be sure to also follow us on Facebook and Twitter, and check out our website. Links are in the show description. Thank you for listening, and we hope you come back soon.